Hello everyone, welcome to today's webinar sponsored by Simon's VIP Connect. Thanks so much for joining us to learn more about autism spectrum disorders. My name is Audrey Bibb and I'm one of the genetic counselors at Simon's VIP Connect. And I'm joined today by our speaker, Robin Kochel, PhD, who is the principal investigator at the Baylor Simon's VIP clinical site in Houston. She's a developmental psychologist in the Department of Pediatrics at Baylor, and she's been researching various aspects of autism spectrum disorders for the past 10 years. Her presentation is titled Autism Spectrum Disorders, Symptoms and Associated Behaviors. The presentation will be followed by a question and answer session, so please feel free to submit questions during the presentation in the chat window on the left side of the screen. The webinar is being recorded, and we will be posting it on our website if you or other family members would like to watch it in the future. Welcome, Robin, and I'll let you go ahead and get started with your presentation.
Okay, great. Thank you, Audrey. Okay, so I'm going to be talking about symptoms of autism spectrum disorders, or ASDs, as I'll refer to them throughout the talk, as well as behaviors and conditions that commonly co-occur with ASD. And here's a summary of the topics I'll be covering today. So we'll first have an introduction about what autism and ASD are, and then I'll talk about the prevalence of ASD in individuals with 16p11.2 deletions and duplications. I'll describe the three main domain deficits that comprise an ASD diagnosis, as well as behaviors we tend to see in each domain. And then we'll watch some video clips to get a first-hand look at some of the behaviors we commonly see in ASD. I'll follow that up with a discussion of associated symptoms and commonly occurring conditions, and then close with information about supportive resources for families of children with ASD, as well as some information about research in ASD. Okay, so what is autism? Autism is a neurodevelopmental disorder that's characterized by social skill difficulties, communication problems, and ritualistic repetitive behaviors. Most often, these symptoms present in children before the age of 3, and in fact, for a strict diagnosis of autism, a child must have demonstrated these symptoms within the first 3 years. Autism is considered a phenotypically heterogeneous disorder, meaning that affected children can look very different from one another in terms of their behavior, their cognitive functioning or IQ, and how well they get along with day-to-day activities. A lot of the time, you may hear people use the terms autism and ASD synonymously. So what is autism spectrum disorder, or ASD? This is essentially referring to any of a group of disorders under the broader umbrella of pervasive developmental disorders based on criteria outlined in the Diagnostic and Statistical Manual of Mental Disorders. Currently, there are 4 different diagnoses that fall under the category of ASD. And these are autistic disorder, or autism, childhood disintegrative disorder, Asperger's disorder, and pervasive developmental disorder not otherwise specified, or PDD-NOS. And I'm going to talk a little bit more about how these diagnoses are distinguished from one another in just a little bit. So you might ask, why are we so interested in ASD among the population of individuals with 16p11.2 genetic differences? And the reason for this is because 16p11.2 deletions and duplications are currently the most common genetic cause for ASD. Together, they account for somewhere between 1% and 2% of all cases of ASD. And I know this may not sound like a lot, but in the world of genetics, it actually is. Now, when we look at just those individuals with 16p11.2 deletions, somewhere between 20 and 30% of them meet criteria for an ASD diagnosis. And then when we look at those with the 16p11.2 duplications, about 20% of them have features or symptoms of ASD, but most often not enough to render a strict diagnosis of ASD. Now, that's not to say that those with the duplications would never have an ASD diagnosis. It's just that fewer of them meet the strict criteria for ASD when compared to those with the deletions. But obviously, this is something that the Simon's Variation in Individuals Project or the Simon's VIP is very interested in looking at. So participating families can expect to participate in various ASD-related assessments. Okay, so moving back to the symptoms of ASD, our focus is really on this triad of characteristics: impairments in verbal and nonverbal communication, impairments in reciprocal social interaction, and restricted repetitive behaviors and/or interests. And I'd like to go over the specific types of behaviors that we see in each of these domains so that folks can get a clear picture of what we mean when we say difficulties in these areas. So in the social domain, we look for impaired use of nonverbal behaviors. For example, lack of eye gaze and facial expressions to communicate. We also assess whether there has been difficulty in establishing friendships with other children or individuals of about the same age. Oftentimes, children with ASD find that it's easier or maybe more appealing to relate to others who are either much younger or much older than they are. Or sometimes what we see is that they just have a more limited number of friends compared to other kids their age. We also look for a lack of spontaneously seeking to share enjoyment, interests, or achievements with others. So this would be the child coming home from school and pulling out all the artwork he's made to show his parents, or the 90 he made on the math test. And children with ASD often don't do this. Or the things that they might share with others tend to be restricted to their very special interests. And finally, we look for a lack of social or emotional reciprocity. And one example of this would be sharing or giving things to others. In the communication domain, there may be a delay in or a total lack of the development of spoken language. Oftentimes, children with language delays will try to compensate for this by using gestures or signs or sounds. However, children with ASD typically don't make efforts to communicate in these other ways. For those children who do develop speech, we find that they have difficulty initiating and or sustaining conversations with others. Sometimes their conversational skills are limited to their favorite topics, or maybe their style is just to ask questions as opposed to making comments or statements. We also see that many children with ASD have stereotyped, repetitive language and or unusual ways of saying things. So in terms of the repetitive language, this could be a child repeating things he's heard from a favorite movie or things he's heard other people say. And then in terms of having unusual ways of saying things, the child might refer to objects or events in odd ways. For example, saying sandy bread for cinnamon toast, or saying it's darking to mean that it's getting dark. And finally, we look for a lack of varied, spontaneous make-believe, pretend play, or social imitative play. And this means that we're not necessarily seeing that the child is taking note of the actions or the routines of others and then incorporating them into their play. In the behavioral domain, the child may have a preoccupation with one or more restricted interests that is unusual in intensity and or focus. And what this means is that she could have a really intense interest in an object that seems very odd for someone to be interested in. That she has an interest in something that other kids her age would not be interested in. Like, for example, maybe an interest in elevators, or spatulas, or dust bunnies. Or she could have an interest in something that other kids her age are also interested in, like maybe Thomas the Train or Dora, but her interest is just much more intense and might interfere with her involvement in other kinds of activities. We also look for adherence to non-functional routines or rituals, and these would be ones that the child comes up with on her own, not those that the parents might help establish, like a bedtime routine. So an example of a non-functional routine for a child might be having to walk up and down the stairs 3 times before eating breakfast. We also look for the presence of any repetitive motor mannerisms. So this could be any hand flapping or any more complicated movements that might involve the whole body. And finally, we note whether there is any preoccupation with parts of objects or the child playing with things in ways different from how they were intended to be used or played with. For example, lining up toy cars as opposed to driving them around, or pulling out the bristles of a toothbrush instead of using it to brush the teeth. Okay, so now we have a pretty good idea about the kinds of behaviors that comprise an ASD. But as you'll recall, there are 4 different diagnoses under the broader label of ASD, one of which is autism or autistic disorder. So how are these other diagnoses different from autism? Well, for Asperger's disorder, we're still looking for qualitative impairments in all 3 areas. So those were the social domain, communication, and the repetitive, restricted behaviors and interests. But what we don't see is any delay in language or cognitive development. And it's on this point that Asperger's disorder differs from what we might call high-functioning autism. Also, for a diagnosis of Asperger's disorder, the child's cognitive functioning or IQ score must be in the average or above average range. A diagnosis of PDD-NOS might be given if the child does not meet enough criteria in one or more of the 3 domains to receive a strict diagnosis of autistic disorder, or if the age at which symptoms appeared was greater than 3 years. So unlike Asperger's disorder, we don't see that there are any IQ requirements for this particular diagnosis. What we oftentimes see is that very young children who appear to meet some criteria for ASD are given this diagnosis and then referred for a follow-up assessment to help confirm whether this or perhaps a different diagnosis is more appropriate. And the reason this sometimes happens is because it's still really difficult for some professionals to recognize the symptoms of ASD in infants and toddlers because they can look really different from the symptoms that we see in preschool-aged and older children. The diagnosis of childhood disintegrative disorder may be given when the child has a clear loss of at least 2 previously acquired skills before the age of 10, but after a period of at least 2 years of typical development. The skills that these children lose are typically persistent, and this is different from the skill losses that we sometimes see among children with autism because those can often be regained. And I'll talk a little bit more about skill losses or regression in autism in just a bit. But childhood disintegrative disorder is extremely rare, and it's estimated to occur in about 1.7 children per 10,000. Okay, so I'd now like to show you some video footage of a couple of children that we previously evaluated for ASD so that you can get a first-hand look at some of the behaviors that I've been mentioning. The clips that I'm going to show you were taken during our assessments using the Autism Diagnostic Observation Schedule, or the ADOS. And this is the standardized play-based assessment for the child. And then for higher functioning individuals, there are modules that have more of an interview component to them. Essentially, we use the ADOS to observe the presence or absence of ASD characteristics based on how the child responds to specific tasks or presses. And the children in these videos were somewhat lower functioning, and I selected these clips because we don't really have good access to sound through this webinar, and we would really need good sound to get a good feel for how responses go with the higher functioning individuals. But the sound is not really important here to see the behaviors. And actually, you probably will be able to hear a few things, but just maybe not that well. Anyway, the first clip I'll show is of a little guy during the first part of the ADOS, which is free play. Okay, unfortunately, that clip cuts off a little short, but what I wanted you to see, and I'll tell you what he did a little bit more, what I wanted you to see was that he took the block and banged it into his fist a few times. And that was a behavior that we ended up seeing throughout the entire ADOS session. So you may have seen that there was a telephone next to him on the table. And what he does next, that I'm sorry you missed, was he took the receiver end of the phone and did the same thing with that he did with the block. So he would tap it in his palm. Then he actually picked up the entire phone and tried to tap that into his palm. So we really just see a lot of the same repetitive behaviors there. You may have also seen him put the book up to his lips. That was another behavior that he did with several different objects. So, and it could be that he was just feeling them on his lips, or it could have been that he was sniffing them. So it could have involved somewhat of a sensory component. So the next video clip that I'm going to show you is of a little bit older guy, and this is during the bubble activity. The thing I really wanted to point out in this particular, there are a couple of things, but during this bubble activity, you know, a lot of kids like bubbles, and when most kids are wanting more bubbles, the way they request that is by asking, using words, or using gestures, or some combination of that. And he was really needing to be prompted to use his words to request. And then at one point we saw him reach across the table and basically use the examiner's hand as if it were a tool. So he's making her fingers work the bubble gun. And that's really not an appropriate social overture. So that's something that we would certainly pay attention to. We also, I don't know if you could hear it very well, but he has a very odd tone to his voice and some very loud sounds that he makes. So that was something that we would pay attention to as well. All right, and the last clip that I'm going to show you is the same kid that we saw in the very first video, and this is during a different activity that is demonstrating joint attention, and it's with a balloon. Okay, and with that clip, the interesting thing about that is he does give her the balloon. So I don't know if you could really tell, but basically the examiner was standing somewhat right in front of him. She would blow up a balloon, and then she would release it. The balloon flies around the room. And we're sort of looking to see how the children respond to that. And what he did was he went over, he picked up the balloon, and he gave it back to the examiner, which was really great. Showed some nice giving. Once he gave it back to her, though, he kind of looks away. He makes some unusual facial expressions and doesn't really make any requests for her to do it again. And he does respond to his name when she calls him, but he doesn't make eye contact with her when she does that. So, I think those are some good examples of some of the kinds of behaviors that we're looking for. So let me go through here. All right, so hopefully the clips have given you a pretty good idea about some of the behaviors that we see in ASD. And if you're interested in getting additional examples, I always suggest that folks look to film because there are several movies that really nicely and accurately portray individuals on the spectrum. One of my favorite movies of all time is Rain Man, but really all of the movies listed here are good films. Temple Grandin and Mozart and the Whale are two movies that are based on true stories. And then Autism the Musical is a really nice documentary that shares a variety of stories from families of children with ASD. Okay, so I mentioned earlier that ASD can look very different in affected individuals. Well, the development or onset of ASD can look very different as well. We know that the symptoms of ASD unfold in different ways and at different times across children. Some of them have developmental delays or differences early on, maybe within the first several months of life, and this is often referred to as a congenital onset. Others seem to be developing typically and then hit a plateau where they then fail to progress at their former pace and begin to show symptoms of ASD. Other children have seemingly typical development followed by a loss of skills, and we refer to this as a regressive onset. But these onset patterns are not mutually exclusive, as some children seem to have a congenital onset and then later experience a regression. And I want to talk about regression for just a minute because it's a particular interest of mine, and I think that witnessing a regression can sometimes color the way that families think about ASD, particularly their beliefs about causes and their choices for treatments. But essentially, a regression occurs in about 1/3 of children with ASD. Most often, the skill losses happen between the ages of 1 and 3, with an average age of loss at somewhere between 19 and 20 months. The most common regressions are noted in language and or social skills, with a smaller subset of children losing other types of skills like motor, daily living, or play skills. We know that children who experience a regression are different from those who don't in that they tend to have lower IQ and adaptive functioning scores, they show more repetitive behaviors, and they also exhibit a greater ASD severity. However, most children with ASD who lose skills do regain them. Before moving on to other conditions that commonly co-occur with ASD, I just wanted to touch on some of the other behaviors that we often see in this population. So these include sensory seeking or sensory aversive behaviors, a sensitivity to loud or specific sounds. So this might be a child's hands over the ears for noises that most of us would not find disturbing. He or she might also have an unusual reaction to objects or events, like, for example, screaming at the sight of a lawnmower. We might see aggression toward himself or others, and we usually hear a lot about picky eaters. So these children may have an extremely restricted diet that is self-imposed, or perhaps they only eat certain brands of foods. And then sometimes children with ASD have an odd or unusual tone of voice. Maybe it's high-pitched or more sing-songy than would be expected. And if you heard that guy on the clip I just showed, then that's kind of what we're talking about. But I just wanted to make note, though, that these characteristics or behaviors are not necessarily diagnostic, and they're certainly not exhibited by all children on the spectrum. But they are things that we hear a lot about. Okay, so moving on to co-occurring conditions. I'm going to briefly discuss some of the more common conditions that we see in the following areas, and that's cognitive deficits, psychiatric conditions, neurological difficulties, and genetic conditions. One of the most common co-occurring conditions we see in ASD is intellectual disability, and this is defined as an IQ score of less than or equal to 70. Intellectual disability is present in somewhere between 26 and 58% of children with ASD. However, the figures vary by type of ASD. So for example, among those with autism, the rate is somewhere between 66 and 80%. For those with PDD-NOS, the rate is just over 30%. And then by definition, we don't see intellectual disability among those with Asperger's disorder. One of the interesting things about children with ASD is that their verbal and nonverbal IQ scores can be quite different from one another. So for most folks, these two scores are very similar to each other, maybe just a few points difference. But many individuals with ASD demonstrate nonverbal IQ scores that are considerably higher than their verbal IQ scores. And then somewhat less often, we actually see the reverse. We also know that the rates of psychiatric conditions among individuals with ASD is relatively high, ranging from 41 to 81%, depending on the sample. Some of the most commonly observed psychiatric conditions are ADD or ADHD, depression, anxiety, and obsessive-compulsive disorder. And in one of the studies I worked on, we had asked families to let us know what additional diagnoses their children had received aside from the ASD diagnosis. And the largest proportion, about 25%, said that their children had also received an ADD or ADHD diagnosis. So inattentiveness and or hyperactivity affects a significant minority of this population. We also see relatively high rates of anxiety and depression, and these tend to increase as children with ASD become teenagers and adults, particularly among the higher functioning children. It's likely that as children with ASD get older, they are becoming more aware of their differences, and this could translate into these kinds of internalizing problems. Obsessive-compulsive disorder is also common among individuals with ASD, and we touched on this briefly when I talked earlier about some of the non-functional routines and rituals that these children can come up with. So this is really an expansion of those kinds of things. All right, neurological conditions are quite prevalent among individuals with ASD. Epilepsy, for one, affects about 30% of individuals on the spectrum. And there are two ages where epileptic activity is at its peak. And one is in early childhood and the other is in adolescence. We also know that children with ASD and intellectual disability are at higher risk for developing epilepsy. Sleep problems affect somewhere between 44 and 83% of children with ASD, depending on the methods used to gather the sleep data, and most of this group is plagued by insomnia. Some researchers have found that children with ASD who have more repetitive behaviors or who show hyperactivity are more likely to have trouble with insomnia. And finally, motor skill deficits are notable among those with ASD. And many investigators are finding delays in motor development in infants and toddlers who are later diagnosed with ASD. Additionally, gait abnormalities or having an unusual walk is often observed among affected individuals. And lastly, the co-occurring genetic conditions. I've divided these into two groups. The genetic conditions that are associated with chromosomal differences that involve many genes, and then those that are associated with single gene mutations. And these lists are certainly not exhaustive, but hopefully this will allow you to associate some additional genetic conditions with ASD. So genetic deletions in specific chromosomal regions include those in the Prader-Willi-Angelman region, the Williams region, the DeGeorge region, and of course the 16p11.2 region. And then we know that genetic duplications of 16p11.2 are associated with ASD. In terms of conditions associated with individual gene mutations and the single genes we often see mutated in ASD, we have MECP2, which is responsible for Rett syndrome, FMR1, which leads to Fragile X syndrome, TSC1 and TSC2, which cause tuberous sclerosis, and then several other single genes listed here. And again, this is not an exhaustive list. So I'd like to conclude with information that I hope is helpful to families if they're looking for news about ASD, supportive resources, or maybe information about research findings or how they could participate in autism research. We know that about 90% of families of children with ASD get their information from the internet. But we also know that not all websites are created equally, so I think it's important for professionals to guide families to trusted spaces. So I think probably one of my favorite places to direct families to is the Autism Speaks website, and their link is posted here. But basically, they really support awareness, advocacy, and science to further ASD. And what I like most about this particular site is that they direct families to local resources. So if you look in the top right-hand corner, there's an orange box that says Find Local Resource. This is a place where families can go and type in their zip code and find helpful resources in their community. Another thing that Autism Speaks offers is what they call a 100-day kit. And this was designed to be used by families within the first 100 days after they received their ASD diagnosis. But I've heard from a lot of families that it's really helpful even long after that. So there's a place on the Autism Speaks website where you can go, you can download an electronic version of the 100-day kit, or if you don't have access to the internet, you can call them or ask them to mail you a copy of the 100-day kit. The Simons Foundation, which, as you know, sponsors the Simons VIP project, they also have a really neat spot on their website that really supports current news in ASD research. So they have some blogs and clips of information that I think for those who are interested in seeing kind of what's the hottest news in ASD research, you can go to this link and find out more about that. And another really nice place where families can go is the website for the Autism Society of America. They offer family support, awareness and advocacy. They also share research news, and we tend to hear a lot of policy information come from the ASA. They have statewide chapters that are broken down by region, and I think in Texas we have something like maybe 8 chapters. I think half of them are in the greater Houston area. But this is really nice for families who might be looking for a support group to go to, so you can actually hopefully find one in your community. Excuse me. The clinical sites that are participating in the Simons VIP project also have information that is helpful to families and resource lists where families can go to get more information about ASD. So these are the links at Baylor College of Medicine, at Harvard Children's Hospital, and at the University of Washington. So you should check them out. I think they're really interesting and helpful. In terms of research, where people can go to learn more about research, there are 3 really large collections that I think are worth mentioning here just quickly. Of course, this is not exhaustive, but the Simons Simplex collection, which you may have heard of, this is a really nice repository of clinical and genetic data from families who have just one child within 1st through 3rd degree relatives affected with an autism spectrum disorder. The Simons Foundation supported this project, and it's really nice. We have nearly 3,000 families participating in this collection now. Another great project is the Autism Genetic Resource Exchange, or AGREE. This is another repository, and contrasted with the Simon Simplex collection, this one is focused on families who have 2 or more individuals affected with an autism spectrum disorder. So we call them multiplex families. AGREE has ongoing collection of data. So if you or someone else you know have 2 or more children affected with ASD, you can go to this website and learn more about it. And if you're interested in participating, like I said, they're still collecting data. And then also the Interactive Autism Network, or IAN. This is a really neat project in that they're collecting all of their data through the internet, so you don't have to go anywhere to participate in their research. And they have literally thousands and thousands of individuals who are participating in this project. And so they both collect data and do research on it themselves, but they also support other investigators by either helping them to collect data or working with them to analyze the data that they're already collecting. Again, each of the 3 clinical sites for the Simon's VIP project has places where you can go and learn about the autism-related research that they're doing, and even have information about what projects they're currently enrolling for. So if you're interested in participating in autism research at these sites, you can go to these links. And I just wanted to make note of, for those who are really interested in learning about autism research and seeing the most updated findings, this is a really nice international meeting called the International Meeting for Autism Research, or IMFAR. It's sponsored by the International Society for Autism Research. The website link is right there posted. Their next meeting is coming up. It's May 12th through 14th. So if that one is too close and you can't make it, the meeting for next year is May 17th through 19th in Toronto. But this is just a really excellent place to hear experts in the field share their hot-off-the-press research findings. And I think every year I meet more and more families who are attending this particular meeting. All right, so that's the end of my presentation. I think there was at least one question, but I'm happy to answer any and all questions.
Okay, and we'll start with the first question, but if anyone has any other questions, please feel free to post them in the chat window. Marissa was wondering, how will the proposed changes to the DSM-5 affect the diagnosis of autism spectrum disorders, and can you comment on whether or not this could affect the relationship between 16p11.2 and autism spectrum disorders?
Sure, that's a really good question. My understanding is that the proposed changes to the autism spectrum disorder diagnoses is that I think they're looking at getting away from those distinct diagnostic categories, so autistic disorder, Asperger's disorder, pervasive developmental disorder, and instead just moving to a single diagnosis of ASD. So you wouldn't have kids who had a diagnosis of Asperger's disorder or autism. Everybody would just have an ASD diagnosis, and then I think there would be like a clinical severity rating that would go along with that. And in terms of would it change the relationship between 16p11.2 and ASD, I don't necessarily think that it would, because we're still going to be looking at the same kinds of characteristics, and there certainly are reasons for why they're talking about collapsing these, and it's essentially because this truly is a spectrum disorder. We really are seeing that these kids have a lot of the same kinds of characteristics. So I don't really think it would change that relationship.
Okay, and it doesn't look like we had any other questions, so I guess we can go ahead and conclude the webinar. Thanks to everyone for joining us. Our next webinar, it looks like, will be on June 17th.